So let's start with today's presentation. So this is actually, for some reason, my favorite slide. And I took this from Hawaii when I was there. So as a physician, what we try to do, we try to put things in a box. We try to define, categorize. I think it's human nature. So if you do see there are fish and they're in a circle, so that's kind of a little house of the fish. It was very interesting. It's a small pond. It's not part of any regular communication with the water channel. It's just the rainwater and small pond with the fish having little houses in it. Let's start with the definition of epilepsy, especially when we come to talk about epilepsy, because the definition keep on evolving over time. As physicians, sometimes we don't understand, but for researchers, definitions means a lot because it defines exactly what we are talking about. So a seizure is a transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain, which manifests clinically as jerking or many other non-motor symptoms. Epilepsy is a disease of the brain defined by any of the following features, which is at least 2 unprovoked or reflex seizures more than 24 hours apart. So if there are 5 seizures happening same day, those are going to be considered as one. One unprovoked seizure with probability of 60% of another seizure is in next 10 years. This term of 60% is arbitrary, so it's not fixed. But it's like, to make it a definition, they come up with this number. So if the probability is high, especially in a period of 10 years, this patient needs to be on a medicine to stop happening the next event. The diagnosis of epilepsy syndrome, which is usually made on EEG, or if there's a clear picture on the clinical assessment based on history. Refractory epilepsy, on the other hand, is the failure of adequate trial of 2 well-tolerated, appropriately chosen and used anti-epileptic medicines to achieve sustained seizure freedom. When we say sustained seizure freedom, it has to be at least 3 times the time between the 2 seizures before the start of the medicine, or 1 year. So that's what I mean when we talk about definitions for researchers. It means a lot, and there is a lot of effort put into defining these words. So it has to be accurate word by word. So as we are talking today about the refractory epilepsy, we need to understand how frequent it is. So it's actually quite frequent. 1/3 of the patients with epilepsy, they can become refractory to the usual treatment. So we have to be very careful about these particular patient population. They do have a poor quality of life, so they are not able to perform well in their routine life, and on top of that, there are higher chances of sudden, unexpected death in epilepsy. So it's a quality measure that the patient with epilepsy, we need to control and provide control as much as possible, because that's going to affect their quality of life. It's going to result in death as an end product. So we really want to make sure that we provide the best quality care, control their seizures, so they don't keep on having seizures. Okay, so the predictors of refractoriness. Again, it's the initial seizure frequency. If somebody is having more frequent seizures in the start of the diagnosis, uncontrolled by the medicine, or failure to respond to anti-epileptic medicine early on, or it could be underlying etiology like focal cortical dysplasia, because the tumors can be removed, but these patients tend to have refractory epilepsy. So this beautiful slide is actually a courtesy of my career mentor, who is a very well-known figure in the US, Basil Abu Khalil. And actually, even for this presentation, I have to talk to him to get some details of the medicine we're going to talk about. So what it does is it defines the epilepsy type, the seizure type. So the big groups, because the definition has changed and the classification has changed since 2017. So the seizure types are focal, generalized, and unknown now. And the epilepsy type, are focal, generalized, combined generalized and focal, and unknown. But then there are epilepsy syndromes. And more importantly, we need to concentrate on the comorbidities. What are the factors which are affecting the quality of life of those patients? And as clinician, what we look for is what's the underlying etiology. It is some kind of structural lesion giving the epilepsy. Is it genetic, what we call idiopathic epilepsy in the past, is now genetic epilepsy. Infectious reasons, metabolic, immune, or unknown. Anti-epileptic choice of medicine is very important. And again, there are certain factors to consider in that case. More importantly, based on the history and examination, followed by EEG and sometimes MRI, what we have to do is to know what type of seizure was it. Is it a probable generalized epilepsy, or is it a focal epilepsy? What kind of generalized epilepsy it could be? And many things become clear when we know the age of onset, because it could be just a benign epilepsy. So we have to be sure, and many things become clear when we get a detailed history of these patients. Then, if we know the basic stuff, then we can talk about the probability of remission. Will this patient get better on this medicine? Is it a generalized epilepsy which responds on a small dose of correct medicine? Okay. Based on the EEG finding, we can monitor the response of the medication. We can also know the type of epilepsy. Radiological findings can, as we just saw, can give us the idea that will this epilepsy be refractory, or there is something in the brain which can make this epilepsy refractory. And genetics, which is kind of stressed recently. I also do genetics as part of my clinic, and it really helps to define the epilepsy syndrome. It's predominantly part of the research, but yes, even coming back to Pakistan, I have done genetic testing in 1 or 2 patients for epilepsy reasons on request of my colleagues, and it is actually very interesting, but that's not my field of expertise. Okay, that is what I will stress upon in today's presentation. So when we talk about the choice of drug, we not only consider one thing, we have to consider many things in our mind as clinicians. So spectrum of efficacy based on our assessment of epilepsy or seizure type, what would be the best choice of drug? The clinical pharmacology, especially will there be side effects? Will there be teratogenic side effects if it's a female patient? And if we do polytherapy, will those 2 drugs will be synergistic? Okay. Or they're going to be drugs with the same mechanism of action and not going to add much to the patient's control of epilepsy. So we have to be sure when we talk about poly medication or polytherapy in these patients. Mode of use, is it IV, is it oral, or is it intramuscular? Especially when it comes to the loading dosages of some medications. Some of the old medicines were predominantly with side effects, but they also have the liberty to be used IV or intramuscular. But in the new time, we need medicine which kind of covers and have multiple routes of use. And another common factor from the patient's perspective, especially in our society, is the cost of the medicine, which actually means a lot. And I even had a discussion today about the medicine which we're going to talk about. Convenience of for the patient, is it easily available in the market? What's going to happen if a patient is unconscious? Will we be able to provide the required medicine, IV or intramuscular or not? So the convenience is very important for patient's sake, and the cost. Next, so keeping these things in mind, in the past few years, there has been many new medicines coming into the market. And actually there are close to 30 medicines right now, which is actually very good. More choices means more liberty for the physician, better choices for the patient. So there are almost a couple in the last 10 years. So these are some of the medicines which have come out in the last 10 years, and actually the process of developing a medicine or a molecule and getting to the point that it's available in the market means a lot for the pharmaceutical industry, and it takes a lot of effort. So I really appreciate them for working it out. So there are a couple, everolimus is mainly for tuberous sclerosis patients. We're going to talk about brivaracetam. Perampanel is a new one, which is also broad spectrum. We're going to talk about these briefly in the next part of my presentation. So this is another slide. So once we look at those 5 pillars or points when we are making a choice about the anti-epileptic medicine, we have to adjust those medicines after starting one, and then we have to escalate care based on the patient or based on the epilepsy. So we start with monotherapy, so we have to do the best suited medicine based on the seizure or epilepsy type, which we just discussed. And then the next part is, if the patient is not controlled, to use more than one medicine. So we're going to do polytherapy, but it should better have synergistic effects. So low dose can cover more, and different mechanism of action. So these 2 points are very important when we are adding another medicine to our patient. The next step, which actually was not new to me because I have been part of the neurosurgery team in the past, but which I have noticed that is very much lacking in Pakistan, epilepsy surgery. So how many epilepsy surgeries we do see in our routine practice as a neurophysician or as a clinician? I haven't come across many. I haven't come across a single VNS. Yes, there are few done in Pakistan. Okay. I even presented a paper in 2011 in UK on vagal nerve stimulator. I know how to manage, but how many we are doing in Pakistan? I know the cost is involved, but that is what I was reading as well, that even in US, only 1% of the refractory epilepsy patients get surgery. So we are far behind that. But we can pick up at any time, and I think that's where my neurosurgery colleagues come in, their expertise come in, because it's a teamwork which gets to this point. But the more important part, especially with respect to refractory epilepsy, is that it really changes the control of epilepsy and their quality of life for these patients. So I would like to kind of stress on this part, that we need to develop more expertise and in the field of epilepsy surgery. It could be resective, it could be vagal nerve stimulator, it could be recurrent stimulator like NeuroPace devices, which were launched just a few years ago. Paper we published when I was working in Saudi Arabia, selective amygdala hippocampectomy. So again, what I meant by that, I really appreciate the input, is that level of surgery, even for resection, and even for the vagal nerve stimulator, I totally agree. It's not only the surgeon's part. Yes, the aftercare is with physicians, and I don't think there is any physician trained to manage vagal nerve stimulator. But it's very easy to manage, by the way. Next comes the general or alternative treatments, or what we can offer beside the routine medications and surgery. Ketogenic diet, fasting even helps these patients. So that could be helpful, especially for refractory epilepsy. The laser interstitial thermal therapy, gamma knife radiosurgery. I think the gamma knife is available, and the laser interstitial thermal therapy, I'm not sure if that's available. Okay. And what's done in these, because as I said, I was part of the team, what they try to do is, if somebody had a stroke or hemorrhage or a traumatic brain injury, those damaged tissue is actually the generator of seizures. So what they do is they trim off those edges, okay, and make it more finer to kind of think that it's not going to create or become epileptogenic. So that's the whole point. So the other important part about the surgery is earlier the better. If your patient is getting to the point or has a lesional epilepsy, traumatic brain injury or something, earlier they're going to get operated, the better it's going to be in terms of the response. So that is a very key part when it comes to surgery for these patients. Vagal nerve stimulator, and the PACE is also called responsive neurostimulation. Okay, so what happened with the anti-epileptic medication? So the first medicine gives you, next slide, can we get to the next? Okay. It gives you almost 50% seizure control. The next medicine gonna add another 15 to 20%. Another gonna add 3. But once you are across 2 medicine, appropriately chosen, well-action medicine in appropriate dosages, and the still patient is not responsive or still having seizures, these patients are refractory patients. So the criteria for referral to surgery, patients is having more than 1 seizure a month, which is actually how frequently we see that. okay, and they have failed 2 medicines. So I think a lot of patients are going to get into that criteria that they need to see a surgeon to get operated.